Tim Cannon and the Women's Heart Health Group for allowing me to speak on spontaneous coronary artery dissection, the state of the science today. I am a cardiologist up at Kaiser Permanente, San Francisco. I'm the director of our Women's Heart Health program up here. I'm also the co-director of our Pregnancy and Heart Disease program. And I see a lot of VEDS, Marfan, Loeys-Dietz patients in our thoracic aortic disease clinic. So I kind of have a genetic aortopathy spin on my kind of niche here. So I'll try my best to outline the things that I think are my anecdotal personal opinion versus what is research-based versus what is consensus-based on this, as you know, relatively rare condition that we're increasingly recognizing around the world. So thank you again for having me. So I think the best resource we have thus far for SCAD is the scientific statement that we put out back in 2018. I don't think a whole ton, unfortunately, has changed since 4 years ago, although I think there are certain associations and variables that we're growing to understand a bit better. But I would draw you back to this consensus document should you have any questions that kind of dabble in all the things that I'm going to talk about today. So what is SCAD? So the definitions and pathophysiology. So as everybody knows, the definition is epicardial coronary artery dissection that's not associated with atherosclerosis and or trauma, including iatrogenic causes. So I'll sometimes get referrals for the little old 80-year-old woman who did have a dissection, but she has diffuse atherosclerosis. And so one of the things to pay attention to is, do we truly think this is spontaneous or potentially a dissection related to atherosclerosis? So that's the standing definition of SCAD. There's two theories for the histopathology. This is very similar to aortic disease, in which we think there's either an intimal tear that allows blood flow into the vessel wall, causing a false lumen, or spontaneous hemorrhage of the vasa vasorum within the vessel wall. And this theory comes about from a lot of Jackie saw up in Vancouver's work showing that when she OCT'd these patients, there was no appreciable intimal tear. And so the thinking is that there are kind of two different pathophysiologies, or histopathology rather, that could contribute to SCAD, but we still call both of them SCAD at the end of the day. So it's just to highlight that you don't necessarily see a dissection flap in some of these patients when you hone in. And a lot of this has also kind of been replicated, unfortunately, on autopsy in the patients that are examined post-mortem, and there's some pathological appearances of spontaneous coronary artery dissection on the bottom right of the screen. So some history. If you look back at SCAD, it was first described by a guy named Harold Pretty in 1930, and I managed to find a picture of him, so he must have been somehow famous in his day. And this was a case of a 42-year-old woman who suddenly died after partaking in a good meal of fried fish and chipped potatoes, which resulted in severe retching and vomiting through the night. She subsequently, unfortunately, died, and the autopsy revealed marked atheroma with dissecting aneurysm of her right coronary artery. So granted, this was kind of an athero-related observation, but it was the first time that coronary dissections had really been described in the literature. After that point, in terms of SCAD, unfortunately, most of the descriptions were in pregnancy. We've now noted that this is probably the minority of cases, but initially it was thought to be kind of a condition around pregnancy. We'll dive into pregnancy a little bit later on in this talk. Historically, as I mentioned, it also been defined as a condition diagnosed on autopsy. So you'll often get patients who will say, how did I live through this? Doesn't everybody with SCAD die? We're trying to kind of change that misconception, but you know, the reason this entity even came into life, into being, was based on autopsy. And so the initial thoughts were, well, the prognosis is very grim in these patients, and we now know better. progress, but a ways to go. So this is a patient I had when I was faculty at Stanford, who came in with a really unfortunate case where her mom had died 5 months after giving birth to her. And she had the autopsy report, which suggested that the left main and the circumflex had dissecting aneurysms. And so she came in with a whole host of questions. Why did this happen to my mom? Is this genetic? What is the likelihood I could have SCAD? My brother to have SCAD? What are my risks if I choose to carry a pregnancy? Is there anything I should be screened for? What are my exercise limitations? My cousin just had a vertebral dissection. Is this related to a familial condition? So I think probably I look back on this case now many years later and think, maybe I would have answered some of these questions a bit differently just based on anecdotal experience over time. But a lot of these questions, unfortunately, remain, the answer remains unclear. The epidemiology. So I just draw your attention to the pictures on the right here. Catherine Leon is the founder of the SCAD Alliance, the organization that I work with that is now closely tied to UCLA, and we'll talk about some of our research endeavors together. She's really spearheaded the effort of getting awareness out both on a professional level for us and from a patient level about SCAD. And she's really just kind of a powerhouse. Tina Pittman-Wagers, she's a SCAD survivor. Tina Pittman-Wagers, also a SCAD survivor. She's a University of Colorado psychologist that works closely with us on kind of the mental wellness aspect of SCAD as an organization. Becky is a rare transplant after SCAD. She was skiing in Colorado when she had her MI, and they quickly got her to transplant, and she's thriving now. Probably, wow, it's been maybe 7-8 years after her transplant. And Naisha Parks is a PhD, also a SCAD survivor, and I bring her up as well because she doesn't really fit the classic face of what we've described as a condition of younger white women. And I'm hoping we dispel some of those myths today based on just some of the data that's come out of our Kaiser database. These 4 women have been very active in the organization I work with, and these are just kind of some of the faces of who may get SCAD. So the true prevalence is unknown. We think in part due to underdiagnosis. You know, we do a much better job now when younger women or women who don't have known comorbidities that would trigger kind of a question of whether heart attack is in play, of screening women with an EKG and a troponin when they come into the ER, but there's definitely still more work to be done. And I can't tell you how many times patients say, I was told I was just anxious, I went home and I came back. We had a case of a patient in Ann Arbor who went to the ER. She was told she was probably having a panic attack, young 35-year-old, super healthy woman, went home, had a cardiac arrest. Her husband resuscitated her, took her back to the same hospital via ambulance, obviously at this point. So, you know, we still have a lot of work to do to make sure that we don't miss these patients. And so perhaps it is a rare condition, but it's underdiagnosed, so it may not be as rare as we think. It occurs predominantly in women. 90 to 95% of our cases are women. I say that, but I had 4 men come see me within the span of a couple of weeks this month. So sometimes it makes me question if we're actually now underdiagnosing men, because we tend to think this is more of a condition of women. So that's something to keep in mind as well. Usually perimenopausal or postmenopausal women. So the myth that this is a pregnancy, largely pregnancy related condition has been debunked, because most of our patients, based on the registry data we have, are in their younger 50s, kind of in that perimenopausal period. We believe it's the most common cause of acute coronary syndrome in women under 50. And although it's a smaller proportion of patients, it's the most common cause of pregnancy-associated MI, even though, again, it's a minority of cases. Patients predominantly white in most series, as I mentioned, but actually within our Kaiser data, which is robust because, as you all are aware, we have a large market share of patients. And so when we can pull data from our databases, we're able to kind of get a little bit better of a sense, at least in California, what the epidemiology is. And about 40 to 50% of our patients with SCAD within Northern California are minorities. About 15% or so are identify as Black, African American, about 18% Hispanic, Latin American, and the rest Asian. And there is a LA Kaiser series that has shown some similar results as well. So we think that the classic kind of description of the SCAD woman may not hold true as much as we had previously thought. And I'll mention that part of that is most of the registries to date have been based at large medical centers like Mayo, and so there, we believe, is some sort of referral bias in terms of who we're seeing in these registries. The etiology and associations. So as everybody probably knows, the etiology of SCAD is unknown. There is an association between SCAD and the following things. So I'll kind of just give a little bit of an opinion here and there on the following things we're going to talk about. So everybody here probably knows the most common association is with SCAD and fibromuscular dysplasia. And this comes about because when patients were getting scans for other reasons, when they got diagnosed with SCAD, maybe they were having really bad headaches or pulsatile tinnitus or bad hypertension. And so they were getting screened for renal artery stenosis or cerebral pathology that might be causing their headaches. There was this finding that there were these kind of stringer pearls patterns in different vascular beds that seemed to be disproportionately affecting these women. And that's when the research started ramping up on FMD. I will say this is the most prevalent association, and depending on the series, about 30 to 60% of the patients will be diagnosed with FMD. At KP, we're on the lower end. The Vanderbilt series, the Mayo series, the Cleveland Clinic series, the Vancouver series are probably on the higher end of the spectrum. I'll talk a little bit about kind of my feelings about what FMD truly means after we kind of chat about what the definitions of FMD are. Rarely connective tissue disease, Marfan syndrome, Loeys-Dietz, VEDS. I'm starting to increasingly think that it's not as rare as we think, particularly in VEDS patients. For all of you genetic cardiologists out there or people with a genetic spin, recently have had a lot more COL3A1 haploinsufficiency patients. So I'm starting to wonder if maybe FMD is kind of a observational diagnosis with a lot of different genotypes in it, and we might be missing some VEDS patients who don't kind of fit the classic description of what is in the textbooks. And we'll talk a little bit about that. So I think increasingly there's some thought that perhaps we're underdiagnosing this. Mark Lindsay at Mass General and the group there just put out a paper kind of making this suggestion. It just came out a few days ago. And so it's very timely that people are observing this. And I'm thankful to that group for looking into this further. Autoimmune conditions, lupus, RA, etc. Classically, we used to screen everybody for autoimmune disease, and I'm sure your rheumatologist will tell you a lot of these conditions are a clinical diagnosis, and so stop sending just like random ANAs and RFs and whatnot. And that holds to be true. So I think the Mayo series a couple of years ago that showed that essentially the prevalence of autoimmune conditions in SCAD is the same as the general population. So that goes to say that it's not a disproportionate amount of patients. And so usually what I do is I screen for anything that might suggest that they may have an autoimmune condition before I start doing that testing, but it's not a routine part of my testing. And then time points of significant hormonal changes. So obviously, if 90% plus of your patients are women, you're going to start to wonder if there is a hormonal trigger for these things. And so while pregnancy, as we talked about, is a smaller percentage of these patients, about 20% of cases, that kind of suggests, well, there must be something, about dramatic hormonal shifts that can cause vascular fragility. And the perimenopausal state is also the other kind of period. So a lot of your patients will say, oh, my periods had started to become irregular. Oh, I just started. I was just told that I am menopausal. Oh, I'm starting to have kind of perimenopausal symptoms. And so those are kind of the two time points that seem to really trigger things. We don't obviously very clearly understand what the true pathophysiology is, but there's definitely some sort of hormonal trigger for these. Emotional and physical stressors appear to play a role. So about 40% report an emotional stressor and 24% a physical stressor. So, all of us have patients who are like, I was sedentary, I started doing boot camps last week. I had one patient who was lifting a really heavy dresser when they were moving, and she doesn't usually kind of weight lift. A lot of emotional stressor things, marital kind of marital triggers, or my cat died. There's a lot of just kind of different stories of kind of sudden shock type emotional stressors. So that seems to be a big trigger too. Men tend to report more physical stressors, isometric exercise, weightlifting, cocaine use. In the case reports, I'm not sure that that's translated to my anecdotal experience, and we just don't have enough men in any of our series to really say. There was a period of time where we said men have more FMD. Now we're starting to wonder if men have less FMD, and it's kind of, the literature is very murky. So the question is the pathophysiology of SCAD in men completely different than it is for women? And that's a lot of we don't really understand SCAD as it is, much less how it kind of affects men and women differently, or may have different disease processes altogether. So I'll just kind of go through our Kaiser cohort very quickly. And some of this I already mentioned, but we have over 600 SCAD patients in our cohort now in Northern California. And this was kind of way back a few years ago when we had just gotten a cohort of about 111 patients together. And this just speaks to, we think that this is a condition that affects all races and ethnicities. In terms of baseline characteristics, otherwise, it's pretty similar to other case series in which the large proportion are women. The age is about 48 to 50, some risk factors, but not the same level of risk factors as you see for atherosclerotic disease. As you can see, hypertension, diabetes, those kinds of things are relatively lower as compared to what you would see with an athero-driven MI. And so this just kind of, again, speaks to kind of the characteristics we've already spoken about. Clinical presentation. So the literature suggests that about 2 to 5% of patients present with cardiogenic shock. I think that it's probably less than that. I think now that we've had increased awareness of just frontline workers, i.e. our ER docs and kind of the first people who see these patients when they hit the emergency room. I think now that we're checking troponins more frequently, EKGs and whatnot, and working patients up, it's probably a smaller percentage because the patients obviously that come in shock are going to have you're going to have a more heightened awareness that perhaps this is there's something going on that you need to look into. So it's probably lower than that. We think about 30 to 50% of patients present with a STEMI, the remainder with an NSTEMI. I think, again, we're going to start to see those proportions change as there's increased recognition of these patients in the emergency room. A negative troponin with an unremarkable EKG is exceedingly rare in this diagnosis. Now, is it because we're not looking in those patients? Maybe, but I'd say I have one patient who had a negative troponin, who had a positive stress test. It's really unusual to not get at least a low level troponin, particularly in the heyday of high sensitivity troponins. Ventricular arrhythmias or sudden death account for 3 to 11% of cases. So we may be missing those patients who have sudden death and either don't make it to the hospital or resuscitation is unsuccessful. I don't know about your institution, but most of the institutions that I've been, we don't do a great job of kind of looking into whether family would be okay with an autopsy. And so a lot of times some of these conditions get labeled as, sudden death for unclear reasons. So we may be missing cases on the other extreme end as well. We think the left anterior descending is the most common affected artery based on the literature thus far. I'd say my anecdotal experience is there's far more like AV continuation of the circ and PDA dissections than I think previously described. And then multivessel SCAD seen in anywhere from 9 to 23% of cases. I know we classically say women present different than men. It's actually not true. The vast majority of women will present the same way as men, whether it's SCAD or athero-driven MI. It's just the rare times where an MI presentation is going to be without chest discomfort, you're more likely to be a woman. So I think this kind of just, illustrates the point that the large majority of our SCAD patients are presenting with chest pain, but every once in a while you will get a woman who presents with extreme nausea or vomiting, diaphoresis, dyspnea, dizziness, sudden death, those kinds of things, and not the classic kind of chest discomfort that you would expect. So our data, just to kind of highlight at least one cohort study, the large majority present with NSTEMI or STEMI, which is what we've seen in other cohorts. We also have LAD as the biggest culprit, much similar to other cohorts, although again, I'll say anecdotally that has not been what I've observed. Multivessel SCAD is less common, and our particular rates of FMD are lower than reported by other centers. And some of that may be we're a big organization with a lot of radiologists, and the scans don't always go to a neuroradiologist with experience or previous knowledge of FMD. Same with, our abdominal scans don't necessarily go to someone who's seen FMD before. So there's probably some under recognition. I'd say someone who trained at places where there was a very robust vascular medicine program, there probably was just maybe some overcalling based on, there seems to be a little bit of a subtle beating here in the carotid artery. So I think we probably need to meet each other somewhere in the middle, probably overdiagnosis at large academic institutions and probably underdiagnosis at places where there may not be a niche in this field. Hopefully this plays, but I don't think anybody here needs an LV-gram in motion to know what Takotsubo's looks like. So one thing we have observed is that there seems to be an overlap syndrome of SCAD and stress cardiomyopathy. And this is another paper that came out in CCI in 2020 as part of the part of my work with the MGH group, just kind of illustrating that we are observing this overlap. The degree of LV abnormality you'll see in some of the SCAD patients seems to be out of proportion to the pathology, the dissection seen. So there must be some sort of overlap that may be the etiology of both conditions together. And a lot of us believe that either Takotsubo's might be a a misnomer. Someone missed the dissection of the LAD that was actually there. We also feel like sometimes you look at the angiogram and the dissection is just in this small little piddly artery. And again, the LV gram or the echo is out of proportion. And so there's probably a Takasubos component as well. So that's something to look out for. There's a question of LAD hinge point abnormality that predisposes to both SCAD and stress cardiomyopathy. There's a lot of, particularly with the Stanford group that when I was at Stanford, I think Dr. Parik's on, he can speak to this. Myocardial bridges are a hot topic there, and we've observed that perhaps bridges may also have a part in these overlap conditions as well. And so oftentimes when I see a woman who has a disproportionate echo, stress cardiomyopathy, and looking into whether there's a significant myocardial bridge is kind of part of the workup to make sure we're not missing something else that kind of might be a two-hit. So diagnosis, obviously, as everybody knows here, coronary angiogram is the gold standard. There's a lot of talk in our world about whether we can get away with a CT angiogram. But as all of you know, it's helpful if you're trying to rule out proximal disease or left main dissection or intramural hematoma. Not going to be as helpful, maybe in the mid vessels too, but not going to be as helpful once you get to the distal parts of vessels. So I'm reluctant to use CT as kind of out of the gate unless there's a concern for athero-related MI or some other etiology, because oftentimes then you're left saying, okay, well, your CT angiogram was normal, but you still had a positive troponin. We don't really know the etiology. So it makes it a little bit tricky to use CTA. The MGH group has also started to notice that they may be picking up some artifact on CTA that's being called dissection flaps. And then when they're taking the patients to the cath lab and OCTing them, there's nothing there. So there's some concern about how to use CT in this context, even with our like super fancy 256 slice scanners and a beautiful study. So it definitely can be used, but you just kind of have to use your judgment. And then I used to say we should really just do femorals on all these patients because they're going to spasm and they're going to have issues in terms of potentially dissecting their radial when you go up. And this is with the caveat that I'm not an interventionalist. I'm married to a structural heart guy who tells me this is not a problem, and he's right. I think we largely do radial approach now, and we have not had, in my recent memory, any issues with a radial approach to cath. You will note in the examples on the right that we see a lot of tortuosity, much more tortuosity in these vessels than you would see in athero-related, unless you're talking about patients with really bad diabetes or hypertensive heart disease. They can be tortuous as well, but tortuosity is kind of a hallmark finding in SCAD that we always note. So I'm just going to draw your attention to figure 5. So this is largely based on Jackie Sah's work out of Vancouver. She does a lot of IVUS, mostly OCT. She's a brave woman in this regard. And so a lot of the identification of SCAD and how we categorize it is based on her work. So box A is kind of the most straightforward. Okay, you see contrast staining, it certainly looks like a dissection. That's a slam dunk. Type B, I'd say type 2 is kind of what we more often see, which is that diffuse stenosis that can be of varying severity and length. And then type 3 is the most challenging. You see this tubular stenosis that often mimics athero. And I'd say this is the hardest one for us in this world, and also obviously for the angiographer, because you're not sure what to make of it and you can't prove that it's SCAD. I will say anecdotally, again, I've had quite a few younger women come to me with a SCAD diagnosis from a type 3 labeled type 3 SCAD without any OCT or IVUS, and then I've coronary CT'd them, and actually it was athero. So you kind of have to be really careful. I think we've done such a good job of educating folks within our region about this potential diagnosis that sometimes I am a little bit worried that we're overdiagnosing it inappropriately. So I think type 3 is the one you really kind of have to be suspect whether you're making the right diagnosis or not. And then if there's uncertainty regarding the diagnosis, obviously IVUS or OCT should be, now I shouldn't say should be performed. I think this is so easy for a non-interventionalist to say, much more anxiety provoking to kind of start shoving things down an artery that you know is abnormal and potentially dissected. So there's a lot of back and forth about whether this is safe to do, what are the outcomes after doing it. Again, Jackie's group up in Vancouver has proven it's safe, but she kind of does it all day long, every day in dissected arteries. And so whether that can be replicated out in the world, you know, remains to be seen. I think your UCLA folks are so well equipped and experienced with IVUS and OCT. I think in experienced hands, in more proximal to mid vessels, it is very useful for those of us who are going to be seeing these patients once they get discharged. And it will confirm the intramural hematoma that we are looking for. And so IVUS versus OCT, I'm not going to belabor this. I think many of you could teach me about IVUS or OCT better than I could, but IVUS, good spatial resolution, can detect tear, false lumen, IMH, thrombi in most cases. OCT is more advanced. It uses light waves to image the vessel wall, and it just has much better spatial resolution. You tend to be able to make a diagnosis more easily. These are just some examples up top. I will say that anecdotally, it's not always so easy, particularly with IVUS, to make a diagnosis. So it's not without its risks, as I mentioned. You have risk of occluding the true lumen, extending the dissection. We generally recommend that you only do this like we were talking about in the type 3 lesions, and when the lumen is large enough for safe instrumentation. So things that everybody in this group probably already knows. If it's a proximal abnormality in question, like I mentioned, sometimes I'll do a CT angiogram instead. I know at UCLA, you guys have kind of the, the cream of the crop in terms of devices for imaging and whatnot. So I think our newer generation scanners, particularly in thinner women with low heart rate, you can get really good imaging with relatively low dose radiation. So perhaps that might be a safer option, is to just take the patient off the table and do a coronary CT to see if there's athero there, soft plaque there, calcium there versus IMH. I will make another note that you also need someone who's experienced in differentiating IMH from soft plaque. That's much easier said than done. So I think also having a reader who has the experience to interpret the findings on the CT are important. And again, sometimes the diagnosis is still a little bit murky, even if an experienced person is reviewing the CT. And this is just one example we had recently. I wanted to play the actual OCT for you, not that you guys need to see it in this group, but just for demonstration, but I was worried the PowerPoint would freeze because it's a big file. So this is just a still image of a recent 35-year-old woman, probably has non-vascular Ehlers-Danlos, which is a clinical diagnosis, as does her twin. They both have FMD. Now it's hard to kind of give people multiple diagnoses. So again, whether that's a kind of a all-comer diagnosis, and when you start to tease it out, it means different things for different people, is yet to be determined. She, I just found out, is 11 weeks pregnant. So she was 3 weeks pregnant when she had her inferior STEMI. So we're sorting that out now, hot off the press. But this is her OCT. And you can see kind of the IMH there. So initial management. We can talk all we want about the diagnosis. I think the tricky part is the management of these patients. So conservative management, the vast majority of dissections will heal within weeks to months of SCAD. This is largely from, again, Jackie Sah's data up in Vancouver. She used to take patients back to the cath lab, and she found that these dissections had largely healed within a few weeks or months. And so we actually just leave them alone, which is, I'm sure, is kind of the common practice for you at UCLA as well. We do tend to keep them for a longer period than our typical ACS patients. And the reason for that is they're not revascularized. And so the concern is that their risk of ventricular arrhythmia is higher. So we like to usually keep them for 48 to 72 hours. The other reason for that is a lot of them have post-diagnosis chest discomfort, and takes a while to kind of Goldilocks the treatment to get them on therapy that we think will kind of calm down the chest discomfort. We reserve PCI and CABG for high-risk lesions, left main, prox LAD, or cardiogenic shock. I say that with the caveat that, we've had some nasty RCA dissections, and the patient wasn't necessarily in shock, where, the decision was made that it might be safer to not kind of let that tissue die and to intervene. So I think a lot of it's a judgment call. I will say that, the problem with PCI is, as everybody in this group knows, that it can lead to dissection propagation. It can shut down the artery. They often end up with kind of quote unquote a full metal jacket. And I will tell you anecdotally, my patients who've had extensive stenting after SCAD are much, much harder to manage symptomatically. They seem to have a lot of more microvascular plugging, and they seem to be more challenging. Now, is that because they had a much more substantial coronary dissection event, or is it something to do with stenting these patients? I mean, nobody knows. And again, just kind of anecdotal. So the general recommendation is to seal the distal and proximal ends to minimize IMH propagation, consideration for direct stenting. There's some, interventional pearls for how to go after these things. And then, the things we're excited about are bioresorbable scaffolds, cutting balloon angioplasty, putting fenestrations essentially in the intramural hematoma to relieve the pressure, decompress the artery. And the reason for that is, the concern is when you stent these patients, once the hematoma heals, are you going to have underexpanded stents, and what are the implications of that? And kind of the similar line of thinking is, well, once the vessel heals, if you've grafted with bypass surgery, those grafts are going to go down potentially. So there's been a lot of talk in our world about whether you should consider just doing a vein graft in certain cases to preserve the patient's lima. Nobody really kind of knows the answer to that. It's kind of an acute judgment call. Assist devices, caution is urged given concern for vascular fragility. Anecdotally, Impella seems to have had some success. There's some concern of shear stress with the balloon pump due to the increased coronary perfusion. Abiomed seems to have had some increasing success with Impella in SCAD patients. And I say anecdotally, ourselves and colleagues around the country have used Impella pretty successfully. And I think most people are pretty comfortable with Impella devices these days. So that seems to be kind of the option of choice if you want to let the patient kind of cool off, but they need hemodynamic support. So you don't want to CABG or PCI them, but you need something for support as they kind of go through recovery from shock. So this is just a case of a patient whose RCA was okay until the second injection, and then the vessel shut down. So just to highlight that, shooting the cores just for the diagnosis in and of itself is not benign. Medical therapy, so heparin, acutely, everyone gets heparin because they're all ACS patients until you diagnose them with their dissection. And I'd say there's no data there's some talk in our world about whether it can worsen IMH. We talk about this a lot in our aortic dissection patients who need anticoagulation post. It's a little bit of voodoo. Haven't anecdotally seen heparin necessarily worsen things. There's also the counter argument that if there's a dissection flap, perhaps the heparin helps with time for dissolving whatever clot might have formed at the dissection. So there's a lot of back and forth. Aspirin, no data. I assess pros and cons and consider lifelong aspirin, particularly in patients with carotid FMD due to the potential stroke risk, but there's really no data for aspirin. Plavix, no data. I do 1 to 3 months, depending on the location of the lesion. Some of my colleagues do none, some do the standard year. I think the take-home point here is don't just throw the same medicines at these patients that you do your athero ACS patients. Kind of be thoughtful about your logic for why you would be giving them each of these things. You have to remember a lot of these patients are still menstruating. Being on DAPT is not pretty for them. So some of them, for reasons we don't really know, seem to have iron deficiency anemia coming in, and that might be one of the triggers or associations. And so I think we just need to be really thoughtful about who we put on DAPT. Beta blockers, only thing that has some data, again, from Jackie Staw's group in Vancouver, there's some signal towards benefit in terms of decreasing the risk of recurrence. I'll tell you that no woman ever has liked a beta blocker. You have to switch them a bazillion times till you find a formulation that works. Nebivolol has been my best friend because it has nitric oxide properties. It's now generic, so it's not as expensive. Although my women have been telling me the generic doesn't work as well as the brand. But that tends to be a really good option. Statins, no data. Some signal towards harm from the Mayo group. We don't know if that's real or not. I tend to just continue it if I think it's indicated for primary prevention, or if I see evidence of athero, non-SCAD related athero or aortic calcification or something that kind of would prompt me to think that the statin therapy would be useful. And then the anti-anginals, you kind of go through the same gamut of things that everyone is aware of: nitrates, calcium channel blockers, Renexa for persistent symptoms. And that's kind of a conversation for another day, how to manage these patients who have post-SCAD chest discomfort that's very difficult to manage. And then how do we manage the sudden death patients? I don't know if there's any EP folks on. This is a back and forth always. When I was at Stanford with our EP group there and here and all the places that I trained, nobody really knows the answer. I'll tell you, this is an anecdotal patient of mine, 50, mid-LAD SCAD, sudden death. She had CPR in the field, EF was 20%, recovered. So she asked me, can I guarantee no future sudden cardiac death? No, I can't. She was like, I have 3 children. I don't know how well you guys know kind of our Northern California geography, but she lives out kind of in the woods in Marin, and that's where she was when she had her arrest. And she was fortunate enough that someone was there who called 911, and she was like, I can't live like that. So we put a sub-Q in. You could argue that was the wrong thing to do or the right thing to do. Nobody knows. I will tell you, our Kaiser data shows that the patients we've put ICDs in, fortunately, have never used them. So the general thinking is that, it stands to reason that you have no idea if this patient's going to have another fatal arrhythmic event with another SCAD. So why would we be putting an ICD in unless you're doing it for the usual guideline directed reasons? So this is kind of a hotly debated topic that nobody really knows the answer to. Non-pharmacologic therapies. Cardiac rehab. So one of the big problems with cardiac rehab, as your cardiac rehab experts know, is that it's really just often hard to tailor it to these patients. I mean, they get pretty demoralized sitting next to the 90-year-old guy who had his, LAD plaque rupture, STEMI. So there's a lot of issues around how to individualize cardiac rehab for these patients in the advent of just kind of limited resource utilization and all of that good stuff. There's data that suggests cardiac rehab is safe for these patients, but the data is going to 70% of folks' max predicted heart rate, which is nothing for a lot of these women. So we want to get them feeling comfortable to do beyond that, but tailoring cardiac rehab to these patients is a challenge that none of us have really figured out yet. And then, as I mentioned, since emotional triggers are a really important part of this condition, you know, kind of getting cognitive behavioral therapy or biofeedback for these patients can be incredibly powerful. Meditation apps, acupuncture, yoga, Pilates, whatever you think you can do to help with the likely PTSD from having an event that you didn't sign up for, i.e. you weren't like a smoker, you know, a lot of these patients, they're doing all the right things and this happened to them. So there's a lot of PTSD associated, but also just what pre-SCAD diagnoses, mental health diagnoses were perhaps missed or not left undiagnosed that need to be addressed. FMD, I think I've chatted longer than I wanted to, so I'm just going to run through these last few slides. But FMD is a non-atherosclerotic, non-inflammatory vascular condition. We tend to screen everybody for FMD these days. So my personal practice is I don't scan the chest. We get really phenomenal echoes here, as I'm sure you do there, that can give me the root and ascending aorta quite well. And so I'm not going to miss much, and I'm not really looking for FMD. So I'll scan the head and neck and the abdomen. And it's a judgment call in terms of what you want to use for scanning. So if you have a phenomenal vascular medicine group with a phenomenal ultrasound clinic, you can oftentimes, the techs can pick up FMD very well, but they'll miss, you know, mid to distal FMD of the renals and up into the carotids and whatnot. But if you wanted to just avoid radiation and focus on kind of, you know, looking at the velocities through the major vascular beds and identifying proximal FMD, you can definitely do an ultrasound. I'll say when I was in training at Cleveland Clinic, they had this amazing program, so they could pick up all kinds of things with ultrasound that I don't necessarily have the benefit of here at Kaiser, so I don't use ultrasound much. CT is really the way to go because it gives the most definitive answer. I'm sure there's imagers in the audience. You know, MR angio is amazing in experienced hands, but the spatial resolution is still not as great as CT is. So if you really want to make sure you pick up even subtle FMD, CT is the way to go. That's been my general practice because it's a one and done. I don't do serial scanning in a lot of these patients unless they have symptoms later. So I feel like a one-time scan probably is worth the risks. There's a lot of argument about, well, like, well, how's it going to change your management? I think the main time it changes your management is if you find cerebral aneurysms. And I think being able to educate your patients on their stroke risk is helpful. I think patients who have refractory hypertension and they get diagnosed with SCAD need to be ruled out for renal artery disease because that angioplasty can be curative in those patients. So you can kind of talk through the risks and benefits. Most of our patients want to be screened. They're all very social media savvy. They already kind of know what they want when they see you. So I generally don't have patients that decline getting screened. And it's reasonable to shoot the renals and iliacs if you're in there and not worried about dye load while you're doing the cath. I think most of us, or most of the practice has gone away from that, but that's definitely an option still. And then, as I mentioned, I'm not going to belabor this. I think my heart's really with the, my passion is with all these kind of connective tissue conditions. And so I'd urge you to take a great family history and take a good look at the aorta to make sure that their Z-score is not beyond what you would expect, even if it falls into normal limits. and get a good family, personal history of, any hemorrhage, colon perf, et cetera, et cetera. This is conversation for another day, but we definitely don't want to miss our Marfan, Loisdietz, VEDS patients. And like I mentioned before, I'm starting to suspect more VEDS haploinsufficiency than I did. So I'm starting to do genetic testing a lot more than I did in the past, in certain caveats. So I think that's just something to think about. The patients I've been honing the most in on are men. I've been sending all my male SCAD patients to genetics, mainly because we're picking up more VEDS. My minority patients, we seem to be picking up a lot more connective tissue conditions without kind of the usual other clinical features that would make us suspect it. And then my patients with significant aneurysms diffusely who are coined FMD, if they have substantial aneurysmal disease throughout their body, I want to make sure this isn't a VEDS mimicker. Pregnancy is also a conversation for another day. We think it's the most common cause of MI in pregnancy, but based on LKM down at USC's data, mean age in the 30s, vast majority, this is the key here, is like any other heart disease and pregnancy issue, this is a postpartum problem. So really, we're really trying to educate our OBs within our region that, hey, once baby's out, you're not done. Like, that's when the risk is there. And so making sure these women don't get discharged, come back to the ER and get dismissed is really key. We think that pregnancy-associated SCAD is much more high risk. Some advocate for avoiding cath and just making the presumptive diagnosis of SCAD unless patients are unstable. And future pregnancies, oh gosh, super uncertain what the risk is. I will tell you, I've probably had about 15 patients get pregnant after SCAD. We historically used to say you couldn't get pregnant, but then the data suggested that maybe we shouldn't be so paternalistic. But I've had one patient who, she had a stillbirth, a home birth. Baby had shoulder dystocia, died. She had SCAD as they were withdrawing care on her baby in the NICU. She wanted to get pregnant again. We did genetic testing. We did the whole gamut. We told her there's this undescribed risk. It's definitely high. I can't tell you how high. She chose to get pregnant. She had a carotid dissection and a stroke a week after she delivered. So 1 out of 14, 15, I know these are small numbers. So it seems to be safe. And that's what our data within our Kaiser system that we published in JACC suggested. But again, when badness happens, it's really bad. So, it's a tough conversation to have. And these are just some diagnoses. So really quickly, the most important thing is to talk about how UCLA has joined our iSCAD national registry, and we're so thrilled to have you guys on board. Thanks to Dr. Cannon's leadership and your Women's Heart Health group. So the mission of the SCAD registry, iSCAD, is to develop and maintain an independent quality repository to advance the pace and breadth of SCAD research around the world toward the common goals of improving patient diagnosis and outcomes and accelerating scientific discovery. This is our steering committee. Esther is at Vanderbilt. For all you fellows out there, if you're wondering how I ended up on the leadership for this, Esther Kim was my former attending at Cleveland Clinic. Melissa Woods at MGH, she was my former mentor at Mass General. And so they've been kind enough to, over the last decade or decade and a half, kind of take me under their wing. And it's been just a privilege to call them colleagues now, weirdly, after many years of mentoring. Catherine Leon, who I mentioned, is the head of the SCAD Alliance, the organization we work with. And so the way that it works is the registry centers, including UCLA, send the data over to Perfuse. So the patients are sending over their patient information, while the providers, the physicians, and your research groups are filling out the patient side information. And all of that data goes to Mike Gibson's group at Perfuse. And they're our core lab for the angiograms, as well as for the data repository. And we check out the data, and we start publishing. And so we're really, really excited. We have 4 abstracts at ACC, and all of them are currently being written up as well. So we're seeing the fruits of our labor. As of January, we had 853 patients, 19 enrolling sites, 2 sites onboarding. And so we're really, really excited with kind of how things are going. And if you look at the literature to date, these are much bigger numbers than, well, not much bigger numbers, but bigger numbers in a short period of time than we have in anything that's published. So we're hoping that we're able to get more robust information on these patients. And then we're kind of the West Coast representation with Providence up in Oregon. I'm hoping we grow our West Coast representation. I think we're very East Coast heavy, but that's okay. And the key elements of that make this registry unique are patient engagement. So the patients are really, this is a grassroots movement. Catherine and the SCAD Alliance raised money to help fund all of our research. None of us really have the resources to help fund it. So it's a total grassroots movement. And so they have we have a lot of patient engagement and a lot of feedback from the patients. And I just wanted to let you know, we do a ton of YouTube talks to educate patients, and I'm happy to send along those links offline so you can send them on to your patients. Oftentimes, we don't have that much time, and your patients may want to talk about cardiac rehab for 45 minutes, and so you can kind of direct them to the links for cardiac rehab, for headaches, and we have experts around the country that kind of talk through the nitty-gritty of some of these topics: pregnancy, hormones, those kinds of things. So these are the abstracts we have cooking for ACC 2022 for those of you who will make it. We'll also have a SCAD Alliance booth there if you want to visit and come say hi and meet folks. And that's it. Sorry I went a little over. If there's any questions out there, it's always so hard on Zoom to field a crowd.
That was fantastic, Sahar. Thanks so much. I really appreciate your vast knowledge about this. We have random patients, and so we don't have a central sort of place to find out about them. That's why we're so excited to be involved with the iSCAD registry. I have to say, in our center, our MR group is very good. Paul Finn with imaging, so we do use him most often. And I've gotten so many variants of unknown significance when I do genetic. It's interesting because there's clearly a vasculopathy or some syndrome going on in a number of these patients. They look a little Marfan-y, but not really. There's just something there. And I keep getting these variants of unknown significance that I never know what to do with. But thank you again. That was a fantastic overview.
Yeah, no, of course. If there's any other questions, I'm happy to answer questions, concerns offline. And again, we're thrilled to have you guys on board, and we're excited to continue to collaborate going forward.
Thank you so much, Sahar. I just want to mention for anyone, this is Marcy. I think we've met by phone a few times at our Women's Talk Center. But Tim Cannon and I have sort of helped start the iSCAD. So we have a system here. It's actually, we've enrolled, I think, 1 patient so far. But it's really easy to enroll them. We consent them. And then, Lene, our research assistant, will help get all the data from them to upload. Basically, it's just consent to have your medical records, in part of the iSCAD registry. So it's really easy. Patients are really excited to be involved. And so let us know if you have any SCAD patients. We don't have to take over their care. It's really easy for us to enroll them either during a telephone visit. We just need to get the consent to them and signed and back to us.
Great, awesome. Thank you all so much. Have a great rest of your day.